Welcome to the Clinical Data Informatics video series offered by SIIM. Today, we'll present a primer to understanding bias in artificial intelligence. My name is Tejani, and I'm a diagnostic radiology resident at the University of Texas Southwestern Medical Center. I do not have relevant conflicts of interest to disclose for this talk. Our goals for today are to understand different types of bias in context of AI, to identify sources of bias both in algorithm development and after deployment, to understand how models can perpetuate bias inherent in datasets, to define inequity, inequality, and fairness, and to propose strategies to mitigate bias in AI. If there's one thing you take away from this talk, it's that bias is a very complex topic. The word bias can hold several different meanings when used in discussions about AI. We're not always talking about the same thing when we use the term bias. And it's important to understand that the definition of bias depends on context. Before we dive into defining bias, why even spend time learning about bias in AI? Well, as developers and users of imaging AI, we have a responsibility to understand how AI ultimately impacts patients and greater society. We are accountable for any harm brought to users or patients by bias perpetuated by algorithms. However, we're just learning about the scope of bias in imaging AI. As leaps in technology enable solutions for a wider range of use cases, we often learn about potential adverse effects in retrospect. Fortunately, we're starting to tackle questions regarding bias in AI head-on. Recent studies show that models can predict demographic information such as race from radiographs, even from distorted images without clear explainability. How is it able to make these predictions? What is the extent of model inference for other similar demographic information? And how does that influence future model predictions? These are all questions that warrant closer examination as we begin to deploy AI models for clinical use. Let's take an example from breast imaging. Here we develop an AI model to identify and segment asymmetries in masses in screening mammograms. Before developing this model, we need to turn our attention to a few important considerations, including: where are the images curated from? Is there overlap between training, validation, and test datasets? If so, at which level? What's the demographic distribution in our training, validation, and test datasets? What about the geographic distribution? How does breast density affect performance, and are there demographic factors contributing to varying breast density? Is there balance in terms of laterality? Are identifying factors like those shown on the tags in these images removed in pre-processing? And can other findings like vascular calcifications invoke associations between chronic illness and race? To further develop our context, let's examine another case. Now we're developing a model to identify fractures on pediatric hand and wrist radiographs. Should models developed on adult patient training data be applied to pediatric target populations? You can imagine this model capturing growth plates and expected finding in pediatric patients as potential fractures in this population. So you may have noticed that these examples involve analysis of more than just pixel data from images to identify potential sources of bias. To cite a few more examples, bias may stem from DICOM metadata, for example with incorrect values. Regarding images, pre-processing may fail to remove noise, including inaccurate tags. And bias may also originate from errors in our radiology reports. Now that we've set the stage, let's talk about bias in this context. This discussion focuses on common, pertinent definitions in the context of imaging AI. But keep in mind that there are more considerations that you can find in machine learning literature, which can be helpful if you're more technically inclined. Generally, bias can be thought of as tendencies towards a belief, idea, person, or group, showing preference to one group or another. We can further break this down to explicit bias, meaning prejudice within conscious awareness, or implicit bias, meaning unintentional, automatic attitudes, stereotypes, or beliefs. However, statistical bias refers to an estimation of the difference between true and expected values. Here we can differentiate between systematic error and random error, with the former referring to reproducible differences exacerbated with larger sample size. We can also talk about algorithm bias, or the tendency for algorithms to amplify human bias present within training data. We'll distinguish this from social bias, or the potential for decisions based on biased AI results to adversely affect underrepresented groups and exacerbate healthcare inequities. More on this later. You may also encounter prediction bias, referring to differences between the average of predictions and that of labeled data. In the context of prediction bias, we can introduce the concept of the bias-variance trade-off. Variance refers to variability in prediction of a given data point, reflecting the range of data. High bias, low variance contexts lend to underfitting, where an oversimplified model fails to effectively capture the patterns in the training dataset. In contrast, high variance, low bias contexts lend to overfitting, where complex models become oversensitive to noise in the training data and fail to generalize. As you can see, the goal during model development is to balance these two factors to avoid under or overfitting. So going back to our discussion about statistical bias, we note that statistical bias in AI may arise from any stage along the AI development pipeline. After identifying a clinical problem and potential systemic biases, we turn our attention to data handling. Bias may derive from imbalanced datasets not representative of actual patient demographics, varying levels of data annotator expertise, lack of standard annotating guidelines, heterogeneous image and scanner quality, and failure to identify data leakage, such as overlapping training and testing data. You may have also heard of data distribution shifts, which serve as an increasingly recognized source of bias. Data shifts refer to the phenomenon of changing distribution of data over time, particularly comparing target or real-world to training dataset distribution. We'll focus on three types of data shift. Covariate shift is the most commonly studied and discussed form of data shift, referring to changes in an independent variable distinct from the variable of direct interest. For example, such as model input features separate from labels that influence a model's output. Changes in hardware, protocols, post-processing software, and patient demographics can introduce covariate shift. In fact, covariate shift is closely associated with selection bias during data curation. Prior probability shift, known as prior, label, or target shift, refers to changes in output distribution with maintained input distribution for a specified output. Concept shift refers to changes in the relationship between a model's input and output with maintained input distribution. Examples can help us illustrate the differences between these types of shift. In the first scenario, the training or source distribution changes from the training to test context due to changing patient demographics. In the second scenario, regarding the input feature of age for the task of detecting colon cancer, the probability of colon cancer is reduced for patients of all ages taking this new preventative drug, but the age distribution, meaning higher risk for those over 50 years of age, remains the same. Now, this example, adapted from Dr. Raim Geiss's article at the ACR Data Science Institute AI Assistant blog, helps illustrate concept shift, where similar input does not associate with the same output, owing to changes in the relationship over time between these two variables. Imagine a model that successfully predicts likelihood of influenza pneumonia based on radiographs in 2018. The same model in 2020 to 2021 may still predict influenza, despite higher prevalence of COVID-19 pneumonia, which may manifest similarly on radiographs. Now in 2022, what would the model predict given rise in vaccinations for COVID-19 pneumonia? Keep in mind that although we can detail different types of data shift, it may be more important to identify data shift and focus on steps to address it in practice versus teasing out the nuances between the different types of data shift. Let's shift the conversation to how biased models can influence clinical practice. Caution is warranted at the time of AI deployment, particularly to minimize potential social bias. Here we see the potential effects of actions informed by output from biased models. Varying access to AI can exclude underrepresented groups from benefiting from solutions shown to improve care, while further perpetuating underrepresentation in future model training or fine-tuning of future model iterations. Furthermore, sources of bias in AI are often identified in retrospect, as it can be difficult to predict real-world factors, such as differing source versus target data distribution. Accordingly, processes for continuous monitoring are necessary for every deployed AI solution. Additionally, inappropriate selection of performance metrics misrepresents true model performance. A quick note here on automation bias. Over-reliance on AI results, despite contrary evidence, enables clinical decision-making based on incorrect AI results, which can exacerbate bias. Lack of expert trained and AI-savvy radiologists can increase the risk of automation bias, allowing incorrect AI results to impact patient care. Ultimately, deploying biased solutions can perpetuate existing clinical bias inherently captured in upstream steps, including data curation and model development. Social bias is the last type of bias that we will discuss in this video. As mentioned before, decisions based on AI results can potentially exacerbate healthcare inequities. You may have seen this image before, underscoring the difference between equality and equity. Keep in mind that these terms are not interchangeable, with inequity referring to unfair differences in health between people of different social, economic, geographic, or demographic groups, making certain groups more vulnerable to poor outcomes owing to higher health risks. Note that inequities are driven by social determinants of health and can be remediated with appropriate intervention. Measuring health inequalities can allow an indirect assessment of health inequity. We're already seeing examples in clinical practice of models amplifying pre-existing healthcare disparities, as groups without access to systems employing AI solutions are often misrepresented by model output. This discrepancy isn't always obvious and requires deliberate scrutinization of deployed model output and context of affected populations. Now, fairness refers to model performance judged against cultural, ethical, and legal factors. We can think of fairness in terms of group and individual fairness, with the former referring to protected groups based on sensitive attributes or identifiable characteristics that contribute to biased models, including demographic information. Let's wrap up with a few select strategies to mitigate bias. Now, a complete conversation on this topic would warrant much more time, but let's think about how we can address bias at different stages of AI model development. We can draw upon the content from earlier in this video to thoughtfully approach steps of model development. For example, when defining the clinical problem, engage all stakeholders during project development. During dataset curation and collection, investigate your data. What this means is ensuring that there's a balance for the demographic and geographic features that we talked about earlier, and ensuring accurate labels across all subgroups. And when annotating your data, standardize guidelines for annotation. During model training, validation, and testing, ensure data splitting. And when you're ready for algorithm deployment and post-deployment monitoring, engage business intelligence tools to ensure continuous monitoring for AI performance over time. There are also select strategies for several of the specific concepts we discussed earlier in this video. For example, when thinking about protecting from data leakage, ensure removal of duplicate patients, meaning split your data at the patient level. When thinking about addressing data shifts, train with large data sets, allowing your model to learn comprehensive distributions to cover all potential target distribution. And if you're thinking about retraining your model, think about whether you'll retrain from scratch or from the last checkpoint of monitoring. And also think about the data that you'd use. Is it from the last 24 hours, the last week, few months, or is it from when you noted that shift started? And when approaching an unfair algorithm, consider a subgroup analysis, comparing performance metrics across different subgroups. Employ fairness checks, allowing you to ask questions such as, does my development team feature representation from diverse ethnic or social backgrounds? Do the demographics of my training dataset match those of my test dataset? Can my algorithm exacerbate healthcare disparities? And which clinical sites will offer AI-augmented care? Are there steps in place to ensure equal access to AI for all patients? And do you fine-tune models on non-target populations? Finally, what are the AI monitoring systems in place and who determines performance metrics? You might start seeing the term intentional bias. Bias itself may be a tool to mitigate AI bias. Awareness of inequitable bias can allow us to address challenges for groups we know are adversely impacted by biased models. We'll call this equitable bias. This includes oversampling data from underserved populations or groups with known history of adverse effects from the social bias of AI models. Models incorporating latent data with insights for disparities can improve model performance for target groups. In conclusion, the definition of bias depends on context, often referring to algorithm or statistical bias with regards to machine learning. Failure to identify sources of bias can translate to biased clinical decisions. Limited access to AI solutions and underrepresentation can exclude certain demographics from benefits and representation in future model iterations. And finally, checkpoints along the machine learning and AI deployment chain allow for early intervention to minimize the influence of bias on model performance. Thank you for your time and attention. We invite you to connect with us at SIIM via social media and join us at the SIIM annual meeting or the CMIMI conference.